Hi, my name is Francesca Cottini. I'm an assistant professor in the Division of Hematology at The Ohio State University. Today I'm going to discuss one of my work, which focuses on real-world data of monoclonal gammopathy of renal significance in the era of novel therapy. So this work is a collaboration with the University of Chicago, and the last author of the paper is Dr. Matthias Sanchez. So MGRS which stands for monoclonal gammopathy or renal significance, is a recently described entity characterized by the presence of a B cell or a plasma cell clone, which produce a nephrotoxic immunoglobulins, but does not meet criteria for other type of hematological malignancies such as CLL or multiple myeloma or lymphoma. Usually these patients are not really responding to immunosuppressive therapies in contrast with other type of glomerulonephritis. They tend to recur, unfortunately, after even a kidney transplant, and they also are at risk of developing a type of hematological malignancy. Traditionally, we have been starting to use clone-directed therapies in this patient using proteasome inhibitors, immunomodulatory drugs, and more recently, anti-CD38 monoclonal antibodies. In our studies, we are evaluating a cohort of 30 patients, and you need to keep in mind this is a pretty rare disease, so it's a good size cohort of patients which were diagnosed with MGRS between 2014 and 2024 at The Ohio State University, at the University of Illinois Chicago, or at the Stronger Soldier Hospital. These patients had a median age of 43, so relatively young patients. Half of them were male and 80% of them were non-Hispanic white. By definition, most of them did not have a monoclonal protein in the blood or any abnormal free light chain ratio. But they had abnormal kidney function with elevated creatinine and also elevated proteinuria. That means they were producing and releasing a huge amount of proteins in their urine. Some of these patients were already on dialysis. It is the way that we do to replace the kidney function, and 7 out of 30 of them had received a kidney transplant. In terms of histopathological changes, by definition, we excluded all type of AL amyloidosis. And so most of the patients had what is called proliferative glomerulonephritis with monoclonal immune deposits or other type as defined by the International Kidney Working Group for MGRS. If we look at type of treatment that they received, a quarter of them received bortezomib-based therapy with either just dexamethasone or cyclophosphamide, dexamethasone, and bortezomib. Half of them had daratumumab added to this regimen, and some other patients had different type of treatment, including immunosuppressive drugs, rituximab, or chemotherapy even. Half of these patients had autologous stem cell transplant as consolidation after the initial treatment, and some of them also had maintenance therapy or a second light therapy. The goal of our study was to see if these novel therapies or this therapy were helping the survival of this patient and also the relapse-free survival. That means being in remission without having the disease coming back. With a median follow-up of 4 years, we saw that novel therapy are able to improve the overall survival of these patients. The 5-year-old survival was 84%. But unfortunately, up to practically half of the patients by the 5th year, they had a disease relapse. There were no differences in terms of overall survival or relapse-free survival based on the type of therapy they received. But those patients who received some type of maintenance with either lenalidomide or monoclonal, like anti-CD38 monoclonal antibody, had a longer overall survival. Our data shows that definitely the use of clone-directed therapies is helping patients with MGRS, even though there is still a high rate of disease relapse. And the next step is really learning a little bit more about this pathology and potentially identify novel target of novel therapy for these patients.